Today journal club topic is in, intubation study, and the presenter is Dr. Sudipto Mukherjee. He's a senior consultant critical care medicine in Tata Medical Center, and also is the editor of ICCM, and also is a chief investigator of a different trial. So I will request Dr. Sudipto to please proceed. A few people already joined, and also they're joining. So we can continue.
Thank you, Dr. Asif, for organizing such a nice academic activity in collaboration with CIPLA. So today's presentation or discussion is on a very relevant topic or a paper which can change or can influence our practice to a great extent. That is the intubation practice and adverse peri-intubation events in critically ill patients from 29 countries. It was published in JAMA in 2021, even among this, between this COVID pandemic. And it is called Intube trial. And it was also important in another aspect. The in this multi-center studies, one of the Indian doctor, that is Dr. Shaila, was one of the chief investigators. So if we look at the background of this study, or whether we need a study on separate study or separate research on intubation protocol and in risk of intubation and related complication in ICU population. What about airway management in ICU? We always consider it difficult, and how it is different from anesthesia, because the patient's airway remains same. One patient may have an undergo a intubation in anesthesia, and this patient may sick in a later half and come to ICU. Does the airway differ? Anatomically, no, but practically we'll see when you go through today's discussion. So, but airways in your intubation in ICU is difficult. That has been recognized very early. This is a paper from 1995. When they look at the risk of the percentage of difficult intubation and the chances of esophageal intubation and associated complications like mainstem intubation, aspiration, and mortality in ICU population. And they have found the first path intubation success rate in critically ill patient is around 73%, which is significantly less compared to if we compare with our anesthesia colleague. And we also found that the risk of cardiac arrest is significantly high in patients who already has a shock or have hemodynamic instability. Even when this part was identified, it was not properly addressed over the years, or it doesn't get its due respect. So does this because we have passed another 20 years from 1995, and still the chances or challenges in terms of intubation in critically ill patient is there. This is a paper from British Journal of Anesthesia, when they found that just like the previous studies, the risk factors for complication in ICU patients are acute respiratory failure, the patient who is in hypoxic, patient who is in shock, and whether there is a presence of an experienced anesthesiologist there or not. And if they look at the immediate complications, it is hypoxia, drop in saturation sometimes significantly, that is less due to less than 70, or hypotension when the systolic blood pressure can drop as low as 70 millimeter of mercury. Even in around 1.5% cases, there is a documentation of cardiac arrest. So now, when you have compared the complication rate between anesthesia and anesthesia practice and also in ICU, this was the observational study done in UK over a similar period of time in the same hospitals. And when they look at the complications of airway management, and the major airway management complications like death, brain damage, emergency surgical airway, or unanticipated intensive care unit admission because of airway related complications is exceptionally low in anesthesia, which is nearly 46 per million cases for intubation. The death is further less, which is around 5.6 per million, even when when the good airway management practice was only present in 19% cases, because the complication rate is very, very less, so everybody take it little casually. On the other hand, though we don't know the denominator, the incidence of major complications in acutely ill patients, that is when the intubation is done in ICU or in ER or in ward when the patient has an acute deterioration, was significantly high, which is nearly 51 cases. The death among these 51 patients was around 61%, which is significantly high, even though the good airway practice, which is observed in around 30% cases. So we can see that in ICU, even when you are focusing or doing airway management in a much more protocolized way, the chances of complication is significantly high. And also there is a significant chance that the complications related to airway was underreported in the anesthesia group. Another paper published in Critical Care in 2017, they also look at the risk factors, more like a physiological risk factors associated with complication in related to intubation in ICU. The number of patients was around 1900. Among them, 49 had cardiac arrest, which is around 2.7%. Among them, 28% doesn't have a return of spontaneous circulation. And among the other patients who has a return of circulation, the chances of mortality, 28 days mortality was around 31%. So though those 72% cases recovered, the significant number of them could not survive the first month. And when you compare it with the other population who did not have a cardiac arrest, the mortality is significantly high. And if you look at the predictors of intubation related cardiac arrest, that is, those are arterial hypotension, hypoxia, absence of pre-oxygenation, BMI, and age. And we can clearly see out of these 5 risk factors, 3 are modifiable. What is the problem? Only problem with this study is a small sample size. The documented cardiac arrest is only 49. Now, so we all know that intubation in ICU is difficult. We always consider them as a difficult airway. But the concept of physiologically difficult airway in this subgroup of patients was a new terminology. And with due course, we understand even some airway is anatomically easy because of the clinical condition, because of hypoxia, hypotension, and other challenges. This can be difficult and leading to higher chances of complication. Those are termed as physiologically difficult airway. And one of the objective way to measure is called Makocha score, which has patient-related factor related to the underlying pathophysiology, and the factor related to the operator. Patient-related factors are mostly related to the airway, anatomy, right, Mallampati score 3 or 4, the patient has obstructive sleep apnea or not, reduced mobility of the spine and limited mouth opening. Factor related to pathology is whether patient is in coma and severe hypoxia. And factor related to operator is presence of or absence of an anesthesiologist, where if we have an anesthesiologist doing the procedure, chances of complications are less. But again, we can clearly see that even in this scoring system, hemodynamic parameter or hemodynamic instability has not been given adequate respect or adequate importance whenever we are reviewing these patients. There are multiple guidelines which try to optimize or try to streamline the intubation policies, but most of them are related to anesthesia, and sometimes they try to extrapolate all those data into critical care practice. I'm just quoting one, which is the All India Difficult Airway Association Guideline 2016, which guides us in terms of unanticipated difficult airway in adults. It was basically prepared from anesthesia. So first line is by standard laryngoscopy and tracheal intubation. They have emphasized on the pre-oxygenation and apneic oxygenation, specifically when it is anticipated there is a little difficulty or we are anticipating a longer duration. If this is not working, we have to consider for different airway manipulation and adjuncts like a bougie or stellate. And to confirm the position of the tube, capnography has a significant role. Now, if this first laryngoscopic attempt has failed after 2 or 3 attempts, we should call for help for a more experienced person or a second operator who can rescue the crisis. And in between, we should consider for a supra airway devices, preferably the second generation, which has a better fitting and sometimes you can ventilate. Oxygenation should always get a priority during the whole procedure. If it fails, we should go for rescue back ventilation. And if it doesn't work, we can consider for emergency cricothyrotomy. And in that regard, availability of jet ventilation and a ENT surgeon can be really helpful. But there are lot of limitations. Again, this protocol is prepared for anesthesia. And so they try to address related to some of the issues related to ICU critical care. Like as I already discussed, patients are very ill with a limited physiological reserve, unoptimized comorbidities, clinical stakes are high and time pressure is intense. So your patient is desaturating, already saturation is 70. I cannot wait till that or a more experienced person is available. This patient needs an emergency airway management or intubation. Inappropriate positioning because of the patient's clinical condition. Sometimes they are not able to position in proper place, like head up, head and up, or sniffing position, and all those things. Immediate environment may be less optimal. There may not be any adequately trained person or extra helping hand in critically ill times, like middle of the night. Do not have much flexibility to examine and assess beforehand because the patients come to an ICU and immediately collapse, and difficult to get an optimal intubating condition. Though I like to give optimal anesthetic drugs and muscle relaxants, those things may not be tolerated by the patient's clinical condition. So because of that, what happened that All India Difficult Airways Society tried to optimize, tried to develop a modified guideline specifically for intensive care units. And they try to focus on certain issues, like they emphasize on the availability of second operator because these issues, these intubations are difficult. Pre-oxygenation, apnea-oxygenation get significant emphasis in terms of either by a nasal cannula or by a non-invasive ventilation, BiPAP, or by a high-flow nasal cannula. And a lot of studies have shown that high-flow nasal cannula, if we use it for pre-oxygenation and for apneic oxygenation, gives a prolonged time for apnea time, specifically, which is helpful in difficult intubation. Induction agents, the recommendations was either to use etomidate or ketamine because they give more hemodynamic stability. Along with that, rocuronium or succinylcholine was suggested for to get optimal intubating conditions. And studies have shown that when you are getting optimal intubating conditions with the muscle relaxant, chances of first pass intubation is high, along with lesser chance of complication. They have also emphasized on cricoid pressure and videolaryngoscopy, difficult airway adjuncts. They also suggest for an intubating bundle so that we can optimize the patient's condition in a protocolized way, and that can reduce the chances of complication. And at the end, they have strongly recommend to use capnography to confirm the ET tube position and to avoid esophageal intubation and related complication. But problem happens that though this was recommended, we are not sure how much we are practicing. Even if you are asking myself that still though induction, as terms of induction agent, still I am using either a midazolam or a propofol rather than etomidate and ketamine. Mostly we use muscle relaxants like rocuronium, and rarely we use succinylcholine. Cricoid pressure we are not using because there is no significant advantage in the other guidelines, and also it makes your airway difficult. Video laryngoscopy needs some extra expertise and sometimes it is not available. People who are using intubation on a daily basis, they sometimes depends on their practice rather than following a certain check protocols. And also there is not enough studies suggesting that protocolized way can help give a better outcome. And still in ICU, though anesthesia capnography is a very standard practice, in a lot of ICUs capnograph is not always available. So from in this regard, this observational studies was into place. That is an international observational study to understand the impact and best practice of airway management in critically ill patients all over the world. Though there are recommendations, we need to review that what are the interventions that we are practicing in our regular life and whether it is improving our outcome or not. So this study was done in 5 continents, 29 countries, and 197 sites had taken participation in it. So what are the objectives? Objectives are to assess incidence and types of major adverse peri-intubation events in critically ill patients. It examined the factors associated with adverse peri-intubation events. It determines the association of adverse peri-intubation events with outcome among critically ill patients. In terms of study design, it's an international multi-center prospective cohort study. The enrollment window was 8 consecutive weeks, starting from 1st October 2018 to 31st July 2019. If two separate ICUs are taking part into the study, they will be considered as a separate center or separate sites. The main ethical clearance was taken by the coordinating center, that is the Comitio Brasiana, in 31st July to 2018. And all the other participating centers get their local ethical committee approval. Either they have taken patient's written consent or waiver of the consent for participation as per their local policy. What are the inclusion criteria? All consecutive critically ill adult patients who are more than 80 years of age, like having life-threatening impairment of cardiovascular, respiratory, and neurological system requiring in-hospital intubation were included. In hospital, and so basically all the intubations that are happening outside the OR, that's the operating room, were included, like emergency room, ICU, or in ward in acutely deteriorating patients. And what are the exclusion criteria? That is out of hospital tracheal intubation, intubation following a cardiac arrest, patients intubated for the purpose of general anesthesia, and also patients who are hypotensive requiring noradrenaline has been excluded from this study. The data was collected in 7 sections. First one is the enrollment, demographic data and clinical characteristics. What is the intubating setting? Patient's physiological parameters before intubation. Detail of the intubation procedure in terms of the technique, drugs, muscle, that is anesthetic drugs or muscle relaxants or the airway adjunct that has been used. Outcome of intubation and status at ICU discharge. So if you look at the primary outcome, it is to determine the incidence and profile of major adverse peri-intubation events. And it includes occurrence of at least one of the following within 30 minutes from the start of intubation procedure. It includes severe hypoxia, that is saturation less than 80, episode of cardiac arrest, or cardiovascular instability, including systolic blood pressure less than 65 for at least one incidence or one reading, systolic blood pressure less than 90 for more than 30 minutes, new requirement of or increased requirement of vasopressor, and patients requiring fluid bolus more than 15 ml per kg to get its desired blood pressure. And what are the secondary outcomes? It includes incidence of cardiac arrhythmia, difficult intubation, cannot intubate, cannot oxygenate scenario, emergency front of the neck airway, that is surgical airway, pulmonary aspiration, esophageal intubation, pneumothorax, pneumomediastinum, airway injury, dental injury, and ICU mortality. So the target of this study was to include at least 1,000 major adverse peri-intubation events, which is a significant number. Previous studies had shown that the expected incidence of at least one major event of major complication is around 28% in ICU population. So the convenient samples of size become around 3,600. In each center, the mean intubation rate was reviewed and it is around 0.2 to 2 intubation per day to avoid over-representation from certain centers so that it doesn't dictate the policies or the expert practice. Even the centers which have a high admission rate, the maximum number of enrollment was restricted to 20. So we need at least 180 centers to reach our target population. So in terms of statistical analysis, for characteristics of the cohort, mean standard deviation or median interquartile range was used. And for categorical variables, we use frequency and percentage. For bivariable analysis, chi-square or Fisher exact test for categorical variables, and Mann-Whitney test or t-test for continuous variable were used. For the post-hoc exploratory analysis, we did a multivariate logistic regression model, and the factors, they look at the factors that is associated with first part intubation success, along with the 20 days mortality in patients with major adverse peri-intubation events, and it has been compared with those not experiencing any of these complications. And eventually they look at the Kaplan-Meier estimates for survival on 28 days from the day of intubation. And the association between the major adverse events with mortality was adjusted for age, sex, heart failure, hematological malignancy, ischemic heart disease, solid neoplasm, and SOFA score. This is the consort chart for this patient. So they started with 3,659 critically ill patients in 29 countries and 197 centers. 540 was excluded because of without life-threatening condition, they don't need intubation, cardiac arrest, out of hospital intubation, or age less than 18 years. So among these 3,119 eligible patients, 126 was excluded because some dozen local investigator available for the data collection, lack of consent, treating physician's decision, and for other various reasons. And among these 2,993, 29 cases was removed because of reintubation or tube changed. So eventually the final sample size became 2,943. These are the baseline characteristics of the patient. Average age was 63. Men are little more dominant, around 62%. BMI, average BMI was around 25. Average median SOFA was 7. If you look at the radiological findings, lung opacity, unilateral and bilateral, was present in around 40% cases. Respiratory support prior to intubation, at least 60% patient was on oxygen. Non-invasive ventilation is present in 21%, and high flow nasal cannula was present in 12% cases. The average PO2 ratio median value was 165, and around 25% of cases was requiring on vasopressor or inotrope support to begin with. Around 37% cases required fluid bolus before intubation. Average blood pressure was around 126 and diastolic around 70. Among these, the most important things we need to remember that even after strong recommendations, the incidence of usage of high flow nasal cannula was not that significant, or NIV was not that significant. They comprises only around 33% cases of pre-oxygenation in this support. Even when the patient has a significant hypoxemia like PO2 around 165. If we look at the intubation policy, 67% cases was intubated in ICU and 21% in the emergency ward. Major reason for intubation was around 52% cases, which is respiratory failure, followed by 30% cases, it is neurological impairment, and only 10% cases, which is because of cardiovascular instability. Among the intubating person, 50% cases, 51% cases was by resident physician, and 49% cases was by the anesthesiologist. So it is around nearly 50% in both groups. If you look at the emergency, intubation was required without delay in around 50% cases, and rest of the case there was some margin. And in around 50%, 46% cases, there is a scope for, and there is a evidence of anatomically difficulty. Makucha score more than 3 was present in around 14% cases. So if you look at this subgroup of population of airway, majority of them was not difficult in terms of Makucha score, even when including the severity of hypoxia, coma, and other physiological variables. If you look at the major adverse events in the peri-intubation period, contrary to our common belief that probably it will be hypoxia, it comes out to be a hemodynamic instability. Around cardiovascular instability was present in 42% cases. In 90% cases, there will be an increased need for vasopressor, drop in blood pressure, requiring fluid bolus, and at the other finding, severe hypoxia is present only in 9% cases. This can understand that because whenever we are intubating, and our understanding for pre-oxygenation is there, most of the time we try to give them supplemental oxygen before doing the procedure if it's not an immediate intubation. Around 3% cases, they found that there is a cardiac arrest. With 52% cases, there is an ROAC, and in 47%, there is no ROAC. Cause of the cardiac arrest, around mostly it is hypovolemia or hemodynamic instability, around 36% cases, hypoxia in 25% cases, and probable thrombosis in 20% cases. And other causes are dyslipidemia, toxin or tension pneumothorax, and cardiac tamponade. If you look at the intubation related other complications, there are documented esophageal intubation, around 5% cases, which is not small, new onset cardiac arrhythmia, difficult intubation, aspiration, dental injury, pneumothorax, airway injury, and pneumomediastinum. If you look at the primary outcome, that is the cardiac arrest or hemodynamic instability or severe hypoxia, it is present in 50% cases when the patient was intubated because of respiratory failure. But it was much higher when the patient has a hemodynamic instability, that is around 65% cases. Among these patients of 2,943 who were followed up in ICU, overall ICU mortality was 32%. But if you look at the subgroup of patients who has a complication, major peri-intubation complication, mortality increases to 40% compared to the other subgroup of patients where the mortality is around 26%. So there is an absolute risk difference of around 15% in patients who have having major adverse peri-intubation event. Now, if you look at the intubation technique, around 50% cases, there is a standard protocol, and 34% cases, and that was followed. 34% cases, there is no standard protocol, and in 15% cases, even though there is a standard protocol, it has not been followed. For pre-oxygenation, most common is the bag mask or standard oxygen. Non-invasive ventilation or high-flow nasal cannula, as we have mentioned before also, was not used significantly. Even though our previous recommendation in our guidelines, usage is only 17%, 16 to 17%. Aptic oxygenation was practiced in only 10% cases. Rapid sequence induction was more prevalent, which is around 62%, and 38% cases, still the required pressure was applied. In terms of method of laryngoscopy, it is still mostly direct laryngoscopy with a McIntosh or Miller's bed. Video laryngoscopy was used only in 17% cases, though it was recommended in our previous studies. Among the airway adjuncts, most common is Stilett, that is around 77% case, followed by Bougie. And the method for confirmation of intubation, still the most common is by auscultation, which is around in 60% cases. And capnography, even though emphasized multiple times in all the guidelines, it is still not practiced judiciously, and the usage is present only in 25% cases. And if you look at the first success rate, which is around 80%, and second part is 15%, and around four cases, they need a emergency surgery or tricothyrotomy. So till now we can found there is a lot of difference in practice when you compare with our national guideline or international guidelines. If you look at the induction agents, like my practice, majority of them are using either propofol or midazolam, which is around 80% cases. Etomidate and ketamine constitute the rest. Among the muscle relaxants, rocuronium is most commonly used, around 40% cases, and succinylcholine is around in 20% cases. There are a lot of data which suggests that succinylcholine, if not used judiciously in critically ill patients, can cause arrhythmia, can cause sudden cardiac arrest. Even now, still around 20% cases, it has been used. And the use of opioid that can decrease the need for induction agent is present only in 50% cases. So if you look at the result, the rate of major adverse event was significantly lower with successful first part intubation. So if compared to the patients who is requiring two attempts, the absolute difference is 8%, and the patients who are requiring 3 or more attempts, the absolute difference is around 14%. And what are the variables which associate with first part intubation? Attending physician, non-anatomical variables, attending physician or consultant trained in anesthesiology compared to a training, anesthesia as a primary specialty, and use of video laryngoscope. Though the usage of video laryngoscope was not that great or now the rampant in this subgroup. What are the other anatomical variables like Mallampati class 3 and 4, reduced mouth opening, neck thickness, presence of beard, high risk of aspiration of gastric content, past surgery, radiotherapy of neck or airway, presence of any other difficult airway predictor, or the degree of urgency of intubation, that intubation is needed immediately compared to when we have a margin of 1 hour, so that we can optimize our patients. So if you look at the post-hoc analysis, the occurrence of a major adverse peri-intubation event was significantly associated with ICU mortality, with an adjusted odds ratio is 1.52. Those patients are followed up for 28-day mortality. The overall 28-day mortality is 30%, with a mortality of 37.7% for patients who have an adverse peri-intubation events, compared to 25% when the patient doesn't have a complication. And even in a multivariable regression model, when they have adjusted these data for baseline patient characteristics, still the occurrence of major peri-intubation events was significantly associated with 28 days mortality, with an adjusted odds ratio of 1.44. So what are the observations we had? We can see that major adverse peri-intubation events like hypoxia, hypotension, or cardiac arrest, though a rarity in anesthesia practice in OR, it is not that uncommon in ICU or in emergency or in the ward in acutely sick patients. The data suggests that the cardiac arrest is around 3% during intubation. Apparently, I don't think we give it enough respect or enough importance whenever we are doing the procedure. Intubation checklist can be a good practice, but still majority of people are not practicing. Even if some of them has a protocol, they are not following it on a daily basis. That may lead to decreased usage of airway adjuncts, decreased usage of available supra airway devices, or capnography when the patient is critically ill, when the patient has an acute crisis. First pass intubation has shown to have the best outcome in terms of immediate and also in terms of 30 days mortality. So our target should be to optimize our intubating condition in every possible way to has the highest chance of first pass intubation success. For that, probably we need a better checklist. We need to make all the drugs available. Use of muscle relaxant is more important. And when you compare the staff physician with a person with a trained background of anesthesia, the chances of success rate is higher for anesthesia people. Role of video laryngoscope has been shown to have a better outcome. Previous studies, multiple meta-analysis has shown that though video laryngoscope has a better visualization or visualization of the larynx, but it does not increase the success rate of first attempt success rate in ICU. Though in tube trial tell a different thing. It shows that those patients who had undergone video laryngoscopy has a better outcome, a more higher success rate. In terms of sedative drugs, if we can clearly see the practice is little different compared to the recommendations, where still majority of them are using either midazolam or propofol. And in terms of that hypotension or hemodynamic instability that has been identified in this study, I think it's a very important learning point from us, so that we can start our vasopressors early to avoid this hemodynamic instability. And even when all the recommendations are strongly suggested for use of waveform capnography, if you look at the practice, the usage is only 25% in cases in ICU, and with the background of around 20% cases of esophageal, 6% cases of esophageal intubation in this subgroup. So what are the limitations? The authors doesn't have direct access to the source of data. It was submitted in a certain format. Not all patients may have enrolled, leading to a selection bias. Selection bias in this participating center will limit the generalizability of the finding, and the interpretation of the results may be biased by residuals and the unmeasured confounders, because these are an observational study. And the study did not collect information on direct long-term consequence of adverse peri-intubation events on specific patient outcome, like hypoxic brain injury. We have followed up for 30 days only in terms of organ failure and mortality. So we are not sure that how many of these patients who had developed a hypoxic insult and apparently well on an immediate basis may have a long-term milder complications. By this, I'm completing my presentation. Thank you.
Thank you, Sudipto. Thank you for a beautiful presentation. And it is very true that in ICU, every Intubation is a difficult intubation, and sometimes we see though we're not able to do malampatti and all. So there are 2 3 students over here. So if you just summarize your take home message for how they will prepare their self before doing intubation, and what are the factors they will consider to avoid complication. Just 2 3 take home message.
So, number one, we should have a clear plan that has been recommended by all the national and international guidelines, and we need to know what is your plan A, what is your plan B, and what are the adjuncts you need for your plan B and C, and those things need to be available. Like if you are going for planning for a video laryngoscopy, that should be available. So also the bougie, stilate, or also a helping hand. It is better to call for help when you are intubating in an ICU, and it is better that you have another person standing at with your and on your side, so that if there is an issue, he or she can step in. Next, this study shows that contrary to our common belief, rather than hypoxia, hemodynamic instability and cardiac arrest is the main complication in this peri-intubation period. So, a lot of time these patients, when we are starting the intubation process, they have a hypertensive response because of acute condition. It is always better to start your noradrenaline early, at least to prepare them, so that once you give the anesthetic drugs to these patients, their sympathetic drive is taken off. Those patients will develop an hypotension. So rather than having a crisis, it is better to start a noradrenaline, prepare a noradrenaline whenever you are proceeding for the intubation. In terms of hypoxia, they have shown that though studies have shown that pre-oxygenation and apneic oxygenation is better with a non-invasive ventilation or an HFNC, it was not adequately practiced. So we need to emphasize on that, specifically in patients whom we are anticipating a longer intubating time. So these two modalities will give you a better oxygenation, better pre-oxygenation. And if we continue with HFNC during the intubation period, obviously it will give us a longer apnea time to handle with the airway. Again, even in terms of ensuring the airway, we need to use capnograph more and more, so that we can prevent undue esophageal intubation and severe adverse outcome. And even after all these things, our success rate in critically ill patients may not be as good as anesthesia, because those patients are more optimally adjusted. But if we follow these protocols, follow a certain checklist, or develop our own intubation bundle in terms of hemodynamics, oxygenation, adjuncts, and other supportive facilities, probably we can decrease these peri-intubation adverse outcomes, including cardiac arrest, to a significant number.
Thank you. uh, Thank you, Sudipto. We can conclude this session.
Thank you everybody. Thank you, Trasif, for organizing this. Good night.
Good.